Thank you. Thank you. So I'd like to make this somewhat informal, so if you have questions, I'll be here at the end to answer some questions, but if there's anything that you find interesting and you have a question while I'm talking, just interrupt, please. My most recent thing I've done at UCLA is developing the Adolescent Epilepsy Center, and it really did come out of some ideas that I saw from my wife, and then also a lot of the teens that I worked with throughout my training. And it really seemed like that's one part of the population that really needs a lot of help. And not only do they need a lot of help, is that we can make a big difference by helping them at that point, and then they can move on to be successful adults with epilepsy as well. So two things I want to really cover. One is comorbidities, because what we found is that comorbidities actually are just as important to diagnose and treat as seizures themselves. The best example I had was a girl I'd been working with for many years, probably about 12 years. She had seizures, were never able to get her seizures under complete control, improvement, but never complete control. And finally, just as she was graduating from high school, her seizures were under complete control for the first time. And I couldn't have been happier. She came back maybe about 3 months later, and her seizures were still under control. It was fantastic, but her quality of life was worse than it had ever been before, even though her seizures were controlled. And that was because when we controlled her seizures, her underlying anxiety came out, and that was actually affecting her life much more than even uncontrolled seizures were. And that was one of the big times that I realized that we really need to be evaluating all this, particularly the psychosocial issues. So about 1% of the population and 1 in 26 people have epilepsy or have a seizure at some point in their life. So this is a pretty common neurological disorder, as many of you already know. This is one thing I like to show is that this is when seizures start. So if you look at here, generalized type of seizures, this is between the ages of 10 and 20. And for focal seizures, the peak is before the age of 1, and then here 8 to 11. So really, it's the adolescent years and the childhood years is when the majority of seizures start. And so that's where I think we need to put a lot of our focus. So comorbidity, a comorbidity is when someone has 2 or more disorders or diseases at the same time. About up to 75% of people with epilepsy in general may have some type of a comorbidity, and up to 50% of adolescents do as well. And those numbers actually may be even low. So here's a nice diagram I thought looked pretty, looks kind of like a flower of epilepsy in the middle, and these are a lot, but not all of, the comorbidities that can be associated with it. So things like learning disabilities and autism, intellectual disability, ADHD, pretty common. Sleep disorders, I was just speaking with someone for the last 10 minutes about sleep disorders in children with epilepsy. Anxiety, depression, these are like just a few. But while this looks nice, this is actually probably more accurate, because very frequently it's not that the patient will only have epilepsy and ADHD. It's often epilepsy, ADHD, plus some sleeping issues, and they're all kind of interacting with each other. And so to treat just one of them, so to treat just the epilepsy, we're missing the boat on a lot. So starting off with depression, just to kind of cover a couple of them, this is from Hippocrates, I think it was 400 BC. Melancholics ordinarily become epileptics, and epileptics melancholics. And the point is, back then we knew that there is this interaction between depression and epilepsy. And if you have epilepsy, you have a much higher chance of having depression, about 30 to 40% of people. But if you have depression, you're actually much more likely to have epilepsy in the future as well. So we don't know all the interaction and all the physiology behind it, but we just do know that there is a clear interaction between the two. In depression, everything from bipolar disorder, regular depression, and anxiety and suicidal ideation we'll talk about in a minute. And when you diagnose someone with epilepsy, the patients are 4 to 7 times more likely to have had depression in the past at the time of diagnosis. So if we're not looking for it and we're not evaluating for it, we're going to miss it. And again, these are the things that can make a big difference. So one of the things we've done is I've brought in, for our adolescent center, is bringing a psychiatrist. Now, psychiatrists and psychologists are difficult to find, probably preaching to the choir, but and many of them don't take insurance, and so it's really difficult to find someone who's good, because the number one thing we need to do is diagnose them. And we don't have, a psychiatrist can't see everyone, so we're doing some things, and a lot of other centers are starting to do this too, and we're doing short little surveys before the visit, and they can kind of flag some people. That can be helpful. So the first thing we have to do is diagnose it. The second thing is evaluating treatable causes. So anyone have an idea of what's one of the most common causes of our patients that have depression? Trauma, definitely trauma. Isolation, good, but something that we're doing to them. Yeah, so unfortunately the medications, all of the medications are affecting the brain, and they may have positive effects, but they also can have negative effects. And so some medications are associated with a higher risk of depression or anxiety. And so we need to figure out if that's the case. And if that's the case, I've got a couple of patients that were perfectly well controlled, but they were really miserable, really sad with the medication. And so we had to switch it, even though their seizures were controlled. And maybe on a different medication where their seizures aren't 100% controlled, but they don't have depression anymore, they have a seizure once in a while, that might be better than complete seizure control, but severe depression. So it's something that you need to work with your doctor, and we need to work together to figure out the best fit, the best way to treat the seizures as best as possible, but without causing any problems. Education, that's the other thing, is these are teens. Teens don't really know, they haven't been around that long, and they don't know a lot, and they may not even realize that they're depressed if they're depressed. And sometimes it's us finding, some little subtle changes. The other thing is that I gave a similar talk to the Dravet Foundation, a group there, and kids with Dravet, or kids who are nonverbal, can be depressed. Now we know that part of depression is situational. Whatever's going on around you, whatever's going on in your environment may cause you to be depressed. That's only one part of it though. The other part of it we know is related to chemicals in the brain. And just because someone has intellectual disability doesn't mean they don't have the same chemicals, and they could have the same ideas of depression. And so these kids may present with different things. So someone who's normally likes certain activities, they have their routine, and for whatever reason they just decide they don't want to do some things that they used to enjoy. And maybe that's just a bad day, but if that becomes a pattern, then we have to wonder, is there a reason that they don't enjoy that anymore? And is there actually some depression underlying that we're not seeing? And so it's really difficult. It's really hard to tease out. And then we count on parents really to work with us to help figure that out. And then, so once we've diagnosed it, we try to treat some treatable causes. Then cognitive behavior therapy. Not everyone can do cognitive behavior therapy. It's not going to be successful for everyone, but we do know there's some data that shows that cognitive behavioral therapy in and of itself can help, and when you combine it with medication management, can make even a bigger difference. So better than just cognitive behavior therapy, better than just medication, the combination does seem to have the best outcomes. Now usually we start with the cognitive behavior therapy because we don't want to add more medications if we don't have to, because the medications, as you know, all may interact, some medications may lower seizure threshold, but some patients need it. And then it's important, and it's really important to work with a psychiatrist who knows epilepsy and who knows how to work with them. And I think that's one important thing when you're looking for doctors, finding someone who's willing to work with your other doctors, because many kids are going to have multiple different things going on and see multiple different specialists, and you need them talking to kind of come together with a clear plan. So that's depression. I love this quote. I just randomly found this online. Telling someone with anxiety to just calm down is like telling someone with epilepsy to just stop having a seizure. So we know anxiety is prevalent. My patient I mentioned before, that was what was really, she couldn't leave her house, she was so bad. And about 35% of people with epilepsy, specifically adolescents with epilepsy, may have some type of anxiety. And whether it's just generalized anxiety, could be panic attacks, social phobia. A lot of kids don't want to go out. Now, some of this may be inherent. Some of it may be chemical, like we talked about before. Some of it may be situational. If you go out and you're at school and you have a seizure in front of your class, and it could be very embarrassing, and that can develop and cause a social phobia. You don't want to go back out again, and you're afraid to go out because of that. So these are things that therapy, again, and possibly medications may help. Even some of the anti-seizure medications may help some degrees of anxiety too. So this is a picture, Jude Russlin has epilepsy, and this is a picture that she created depicting her anxiety. A couple of risks that we know of is the persistent seizures, and then a couple AEDs, anti-seizure medications, do seem to maybe increase the risk of felbamate, levetiracetam, and zonisamide. The other thing, though, is that when you look at these medications, you go online, you're going to find a laundry list 2 or 3 pages long of every side effect possible known to man. And it's, it would frighten anyone. But the key is to speak to the doctor, speak to your different doctors and see, because not everyone's going to get these adverse effects. Most people are not. But if you happen to be the one that gets it, then that might not be the best medication for you. Okay, so what else do our medications do? So they can cause hair loss where you want hair growth where you don't want hair. They can cause weight gain, and in some cases can actually cause weight loss. They can cause cognitive problems, cognitive slowing. They can cause you to be tired, sleepy, or they can have the exact opposite and cause insomnia and prevent you from sleeping. And then finally, irritability and crankiness. And some medications can do that, and there's some data to show that. But again, I reiterate that just because the medication causes one of these things doesn't necessarily mean it's going to happen to you or the adolescent, your adolescent. But things to watch out for. So suicide, an important topic that we don't talk about enough. There's a lot of conversation about SUDEP, which is very important too, don't get me wrong. But suicide is 2 to 3 times higher than the general population rate of suicide. And I'll be honest with you, I've been at UCLA 14 years. For the first 12 years, I would say, I maybe sent 2 kids in 12 years to the emergency room because we're having suicidal thoughts or suicidal ideation. In the last year, since we started the Adolescent Center, I've sent 4. So I don't know whether it's because I now have a psychologist and psychiatrist with me and they were able to tease things out that I wasn't. Maybe I wasn't looking for it hard enough, but it has shown me that it's there and we need to be talking about it, we need to be asking about it and find out early. Risk factors, people with anxiety, about 33%. This is a study that was done by Raquel Kaplan with suicidal ideation. In her study, about 20% of patients that she looked at with epilepsy had that. About 33% also had anxiety or depression. So again, a lot of these comorbidities come together. Other risk factors, comorbid psychiatric disease, the first 6 months of diagnosis. And I think, although I don't think there's great data to show this, but I think a lot of this is based on education and education and understanding the diagnosis, understanding epilepsy a little bit. It's going to take a while to really understand it, but the more educated you are, the more you know, I think the better. And it can be more associated with temporal lobe epilepsy or post-temporal lobe epilepsy surgery. ADHD, very common. Interesting in epilepsy, about 30% of adolescents with epilepsy have ADHD. In intractable epilepsy, about 60% do. And in the general population, it's 6%. So we know that there's something going on with epilepsy and ADHD. Now, compared to general population, it's much more commonly to be inattentive than combined or hyperactive. And in the general population, it's much more commonly diagnosed in boys than it is girls, although there's some debate about whether that's just our acknowledging it or our seeing it in girls. But in epilepsy, it does seem to be pretty equal. Now, one thing you'll hear about, and a lot of people are scared of, is treating ADHD because, I'll get to that. So again, ADHD and epilepsy also have this inverse reaction. Diagnosis of ADHD is 3 times more likely to develop epilepsy. 30% of ADHD plus epilepsy have a 3rd comorbidity at least. And new epilepsy diagnosis were 2.5 times more likely to have a history of ADHD. So back to treatment, stimulants. So everyone's afraid because of concern of decreasing the seizure threshold by stimulants. There are some older studies that did show a mild increase in seizure or decrease in seizure, more likely to have seizures, increase in seizure frequency with stimulants. Newer studies have actually not repeated or have not been able to replicate that. And it does look like the majority of stimulants are fine and are not going to increase seizures. Now, I've had patients who it did seem to increase seizures and they were fairly well seizure free. We started a stimulant and they had a breakthrough seizure. What you need to think about, and I think you need to talk to your doctor about, is what's the most important thing? Is the most important thing controlling every single seizure, or is the most important thing quality of life? And if a stimulant is going to cause a seizure once in a great while, however, now you're able to sit in a class, you're able to learn, you're able to retain information, that may be more important than complete 100% seizure freedom. So it's things you need to think about. Everything's kind of a risk-benefit ratio. But stimulants are not a complete, are definitely an option. Autism, about 20 to 30% of patients with epilepsy also have autism, and the same in reverse. Intellectual disability, it depends on the study. Between 20 and 40% of patients with epilepsy have intellectual disability. This, I have to throw, I'm an EEGer, so I have to throw one EEG up here. This is ESES, many of you may have heard of. This is the spike wave discharges in sleep. And we know that this can affect language, and this can affect development as well. And so intellectual disability, you have a child that's in, or an adolescent that's in school, so they may be having some difficulties because of having a seizure in school and having some bullying issues, but also now maybe they have some intellectual disability, and that's going to cause more problems with them at school as well. So things we need to look out for, and we need to help counsel. Psychosis. Psychosis is something we rarely talk about, and it's not that common, but it does happen. And it's interesting because you can have psychosis during the seizure, ictal psychosis. And by psychosis, you can have, either forceful thoughts, you can see hallucinations, a variety of things like that. But you can have it during the seizure, you can have it right after a seizure. And some people can get very confused and combative, or can actually have psychosis after a seizure. Or you can have interictal, so in between seizures. Post-surgery may play a role, may increase this, and some AEDs may increase this as well. I had one patient, I won't mention the medication name, but I probably shouldn't, but we put him on a medication, and his seizures were fairly well controlled, and Dad said he was walking around the house going like this, and like, what is he trying to do? And when Dad was able to finally get him to talk, he said he's trying to catch the butterfly. Like, butterfly? And I realized I just started this medication, so I said, okay, let's bring the medication down. We took the medication off, and he stopped chasing the butterflies. So medications can cause things like that, and without really thinking about it, you wouldn't think to figure out what is he actually doing and why is he doing that. Sexual dysfunction, something that we don't talk a lot about either, particularly in a teen or adolescent group. However, this is the time when teens and adolescents are looking into this. And so they're not educated about it themselves, and so they don't know what normal is necessarily. And so they don't know what abnormal would be. So it's important for us to educate, and then educate that there could be problems, and if there are problems, they need to speak with their doctor or someone else in the office, psychologist, psychiatrist. It's really important to bring that up. There's women's issues, teen women. That's my wife, Kelly. I often like to show her picture because that's our kids. As we said before, Kelly has epilepsy, and we have 2 children who are both doing really well. But in general, in women's issues, you can have hormonal changes. Catamenial epilepsy is epilepsy associated with the hormonal cycle. And so teen girls who are just starting to get their period, their seizures may become kind of out of whack with the period and at certain times during the month. We kind of talk about when kids go into adolescence and puberty, about a third get better, a third stay the same, a third maybe get worse. I've seen all of the above. And it's really, there's no good data to show why one person gets better, one person gets worse. Unfortunately, it's not one specific type that necessarily gets better or worse. Birth control can be very helpful, especially patients with catamenial epilepsy. And we tend to call it hormonal therapy rather than birth control, because a lot of people don't want to think about their 15-year-old on birth control, but it's really hormonal therapy that can help the catamenial epilepsy. And then folic acid, the importance of folic acid, because accidents happen. People are going to get pregnant here and there, and without folic acid, you can have some severe disabilities and severe damage to the baby before it's born. So basically all of what I talked about kind of goes back to quality of life, and that's what I try to preach, is that I think that's the most important thing. And not everyone necessarily may agree with me, but it's really that the quality of life that I think is what we need to be focusing on. Some things we've found, risk factors to decrease quality of life is lower IQ, polypharmacy, so multiple medications, greater seizure frequency, so having more seizures, fewer family resources, caregiver unemployment, and depression and anxiety in the caregiver. So, it's hard being a caregiver, but it's also very important, and the caregiver yourself has a great impact. Like any parents have a great impact on their child for a variety of different reasons. There was a study that looked at a variety of different chronic illnesses, and they looked at asthma, they looked at diabetes, juvenile rheumatoid arthritis, and all of their quality of life was better than those with epilepsy. So even though a lot more money is going towards a lot of these things, we know that epilepsy actually can have a much bigger impact than a lot of these other. And interestingly, it was actually the same impact as HIV does, which was pretty staggering. About 75% of adolescents have social problems. If they have social problems in adolescence, if we don't intervene, they're going to have social problems as adults. And the sooner we intervene, the better. They found in one study that they had fewer social supports. They had less schooling in general. They weren't graduating from college, even high school. Lower levels of employment. They were less likely to marry and less likely to have children. There's a variety of reasons for all of this. But these are all things we need to consider, we need to keep in the back of our minds, because we need to address them sooner. The sooner, the better. This is just an interesting story, because an interesting article talking about stigma. And we know that stigma still exists. I mean, over the time I've been doing this, I do think it's improved. I think it's improved because of education. I think we need a lot more. This was a study, and they looked at teenagers, and they asked them what their perception of epilepsy was. And these are just a bunch of random teenagers in a couple high schools. They felt that kids with epilepsy were bad at sports, unpopular, dishonest, and without compassion. That one I just don't get, where you get without compassion. But this is what their opinion was. And 20% of them said that they wouldn't want to be a friend of someone who has epilepsy. And 12% said their parents wouldn't want them to be friends with someone with epilepsy. So again, these are all, things are happening, things are going on, we need to know about it, we need to educate. Self-esteem is a problem that relates to all of this. A lot of adolescents have low self-esteem scores compared to asthma. Again, compared to another chronic disease you're taking medications for that can affect you physically, can affect you outside. I mean, kids have asthma attacks in front of other kids. With 22% of patients with epilepsy, teens with epilepsy, had self-esteem issues compared to only 8% of kids with asthma. Some risk factors, longer duration, depression, anxiety, ADHD, and parental unemployment all seem to be, at least for this study, risk factors. Another study, I think is the last study we cover, kind of goes back to what I was talking about as far as education. And I think it's phenomenal that you're all here because you're educating yourself. And there's a lot of information out there in the expo, a lot of information. But this is looking at adults, they were young adults, and what their general knowledge was about epilepsy. So about 43% knew the type of seizure they had. 55% knew what the underlying cause was. EEG, 97% had no idea what their EEG showed. MRI, maybe 20% knew that. And their name of anti-seizure medications were about 80%. So I think that's good. But I think this does show the amount of education that's needed, and this is where the transition, which I'll talk about next, is going to be key, is educating them about all of these things. When someone leaves our practice to go to an adult neurology practice, we want them to know what their type of seizures they have, where they're going to get their medications, what medications they're on, what their doses are. And these are things where you start focusing on over time. Interestingly, this is, again, a group of young adults with epilepsy. A third thought the epilepsy was a symptom of mental illness. 8 patients actually thought it was contagious. These are people who have epilepsy. 40% thought they should stop their anti-seizure medications during pregnancy, and 40% they thought they should lower their anti-seizure medications when pregnant, even without talking to their doctor. So a lot of misinformation, even with patients with epilepsy. So there's a variety of other topics that are important. Adherence, something we work on all the time. Sleep disorders, non-epileptic seizures, non-epileptic events. SUDEP, there's tons of discussion about that now, which is fantastic. And bone health. When kids are on medications for a long chronic period of time, particularly older medications, they can have some decreased bone density. And so at the age around 21, we usually get bone density studies to watch. Exercise tends to be one of the most important things that can help. So to try to figure this all out and try to improve all this, one thing we talked about, and it took us over a couple years to do, but we opened up a Multidisciplinary Adolescent Epilepsy Center. Not a whole lot of literature to show this, but this was one study from Canada that did show this center that had a neurologist or neuropsychologist, a social worker, and an education specialist. And they found that the patients, after going to this multidisciplinary center, they were on less medications, less polypharmacy. Their adherence to medication was better. They more likely were independent from their parents. They were participating socially more, living independently more, and had more employment. So this specific group has really made some differences. So we put together the Adolescent Epilepsy Center at UCLA. And this is our group. And what we have is, it's an integrated clinic. So we brought a psychologist, a psychiatrist, social worker, occupational therapist, and nutrition in to work with the epileptologist to kind of have this integrated biopsychosocial approach. And this is really looking at the bio part, which is what I'm doing most of the time, looking at the epilepsy, but we're also bringing in the psychologist to look for the depression and anxiety, and psychiatrist to treat that, and then the social aspects between the social worker, nutritionist, to kind of pull it all together and kind of basically treat the whole patient. This is a shameless plug. We have a support group. It's the first Thursday of every month, but it's changing. So we do have one this week if anyone's around Westwood on Thursday. But we are changing this because we thought it was a good idea because we have clinic on Thursday. We thought people would stay after clinic and go to the support group. Hasn't worked as well, and it does seem that this is going to work better on the weekends. So starting January, we're probably going to be doing it on Saturdays or Sundays, but we'll have more information out there about that. But I think this is really important. And when we started the center, this was one of the big things I really wanted to do because so many kids, when I talk to them, when we first see them, we first diagnose them, do you know anyone who has epilepsy? No. Many kids, and kids who have had epilepsy for years, never met anyone else with epilepsy. And so that also works, I think someone said before, isolation. That's a big part of the isolation, not knowing, not realizing that other kids have this too. And bringing teens together, I think is really important. We faced some challenges, and like I said, we're changing things around. If you're in Orange County, there's a group in Orange County. I think they have one of the first booths here that does an amazing job of a support group every, I think it's once a month on a Friday. They're doing an amazing job. We're trying to model some of the stuff we're doing after them. So that's kind of adolescents with epilepsy a bit in general. The next thing is transitioning, and that's, I don't know if they're gonna have to change the word because transition now means a lot of different things. And when I say transition, I usually get strange looks at it, like, I thought you were dealing with patients with epilepsy. This is a different transition, but it's transitioning from pediatric to adult care. So what's the difference? We have adult providers and pediatric providers, and so one of the things is training. So for example, we do, everyone does undergraduate, everyone does medical school. Residency for child neurology is 3 years, one of which, we do 2 years of pediatrics, and then 3 years of neurology, one of which year is adult neurology, and then 2 years of child neurology. And then after that, 1 or 2 years of epilepsy. Adult neurologists have a 4-year or 3-year neurology program, and only 3 months of that is pediatric epilepsy. So as a child neurologist, I get a lot more adult neurology than adult neurologists get child neurology during their training. And we're trying to, we're pretty aggressive with our residents, and we're trying to train them better and train the adult neurology residents better so that they will feel comfortable with our patients, because a lot of them don't. There are much fewer pediatric neurologists and pediatric epileptologists in the country, so you would think that because there's fewer of us and many more adult neurologists, it'd be easy to kind of plug our patients in. Not so much. Something that we're working on. A lot of the adult neurologists, when you speak with them, they feel that their frequency of visits, we tend to see our patients a lot more frequently and a lot longer. Adult neurologists tend to have shorter periods of visits, like 15, 20-minute visit, and they can only see someone every 6 months or something like that, where we may be seeing someone monthly for a while. So that can be really difficult. And that's a big, drastic change overnight for someone, for a family. Resources available, a lot of adult neurologists don't quite have the resources. They don't have the social worker and things like that. Pediatric people don't either. But then there's the model of care. And, we tend to practice this family-centered, and I'm generalizing, so if there's any adult neurologists in the room, don't throw anything at me. Because there are some adult neurologists, epileptologists who are fantastic, don't get me wrong. But in general, our model of care is family-oriented. We're working with the whole family. We're working with the parents, the grandparents, the caregivers, whoever, because you or they know their adolescent the most and the best. You're with them all the time, you know what's going on, we're just hearing it from you and the teen. And so we work together as a team. The adult care model, they're used to dealing with them and the patient. And when their patient is 20 and is intellectually disabled, there's a limited amount they can do directly, and they need someone, they need the caregiver to help. And a lot of neurologists aren't used to kind of that interaction, that dynamic. This is another plug for our trainees. We're trying to train adult neurologists to understand these types of disorders, these types of seizures that they're not used to seeing. So if you're at your doctor's office and a trainee comes in, hopefully not with the Medicine for Dummies book in their hand, but you have to tell them your story for the 20th time or whatever. The reason is we're not trying to torture you. It's just that we're trying to educate our residents, the child neurology residents, the pediatric residents, and the adult neurology residents, because the more they understand, the less we have to do, and the more patients we can see. And so if the pediatrician understands pediatric neurology more, understands epilepsy more, there's more that they can do. If the adult neurology practitioner understands pediatric neurology, they'll feel more comfortable taking our patients. And so it's really this education, I think, is going to be where we're going to make the biggest difference and where we're going to improve this transition of care. So the Child Neurology Foundation did a fantastic job putting together these 8 common principles to assist with the transition of care, and that's the 8 on the right side. And their website's great. They have a lot of information. They have a lot of videos that talk about transition, and a lot of some of it's for faculty practitioners, but some of it's for families as well. And then they had a group that took these 8 principles and made it into kind of more of a stepwise fashion. I'm just going to want to go over that quickly. So right now, we're trying to implement a more formalized program. We're kind of implementing this within the clinic right now and trying to work on these things together. But hopefully in the next 6 months or so, we'll have a more formalized program. But the first step starts at the age of 12, and that's just introducing the concept. And the transition compared to transfer. Transfer is, here's my patient, take my patient, bye. And that's what we unfortunately have done for a long time, and now we know that doesn't work well for anyone. And so now we're hopefully working more of a transition over a time so that the patients feel more comfortable, the adult neurologists feel more comfortable, and we need to introduce this early. Most of the time, or very often, people are talking about the age of 16, 17, 18, like, oh, can you still see me? She's turning 18 or he's turning 18. So we want to introduce this idea earlier. So hopefully by the age of 12, or that's the age we're looking to get to, just to introduce the idea that, pediatrics is different. We're going to be working with you for a while. We'll get you in as great shape as we can, and at some time you're going to have to move on to an adult practitioner. The second thing is around also 12 to 17, explore financial, community, and legal support available. This talks about things like the conservatorship. And this is something people don't think about and talk about. And I've had plenty of parents, come up at the age of 17, say, what do we do next year? Are we still going to be able to make decisions? They don't realize that they need to conserve their son or daughter. And this is where we brought a social worker in to help us with this, to help educate and to help move things along. And really, these kinds of things definitely should be looked at probably at least around the age of 16, because sometimes conservatorship can take a year or so to get all the paperwork and everything processed, and usually will require a lawyer who's familiar with all of that. So determine transition readiness. These are self-care assessments for both the patients and their caregivers, and kind of look at a variety of different things, and it's more of a checklist of what are important things to think about and to look for, and at different stages, and this is what we're working on now, at what ages do we give these different checklists and see where you are, and it's supposed to be like kind of a slow progression. So I don't expect a 12-year-old to understand what type of seizures they have, what medication they have, what the dose is, where they get their medication. But at least they should know that they have epilepsy and basically what a basic seizure is. But maybe by 13, 14, now they need to kind of know what kind of epilepsy they have and what medications they're on. Maybe by 15, 16, the dose of their medications. They should be maybe taking the medications themselves more often than not, so that by the age of 20 or so, when they're ready to transition, they understand all this. Now, this is half of the story, because not all kids are going to be able to do all of that. And that's one thing that they've done a really good job is they have different checklists for kids who are going to be able to go off on their own, and other kids that are going to need more support. And I'm glad that they kind of saw that and are working with that. And this also goes along with addressing risk factors for unsuccessful transition. And it's separated into A and B because I think it's one group is for people or teens we think are going to be able to live on their own. Another group is for teens that may not. And so there are different checklists, different things that we look at, and different goals that we have. So the other thing, part of what adult neurologists, when I speak to adult neurologists and adult epileptologists, part of what they are concerned about, what scares them, is the diagnosis. They're not used to having kids with Lennox-Gastaut, Dravet syndrome, some of these genetic diagnoses, and we know that genetic diagnoses we're getting more and more and more, and it's hard for us to keep track, much less an adult neurologist who their last patient had Parkinson's, the patient before that had Alzheimer's, and now they have someone who had Dravet syndrome. Very, very different. So I think around this age, 16 to 19, we need to kind of take a step back and look, what's the diagnosis? Do we know exactly what it is? Are we confident in it? Do we have genetic testing maybe? And that's something that's new, and that more and more people are getting genetic testing. It's going to be easier to get soon, cheaper to get soon. And so this is a good time to reevaluate that. Maybe we need another EEG, maybe we need an MRI, or maybe we're comfortable with all of that. But we reevaluate and kind of reconsider. And along with reevaluating the diagnosis, reevaluate the treatment. Too many times we have kids, and we're all guilty of it. If someone tells you they're not, they're lying, that, we're on a medication and seizures started to break through, so we added another medication. Things got a little bit better, but not perfect, so we added another medication. Well, what's the first medication doing? Well, their seizures are under pretty good control, so I'm afraid to take off the first medication. So we said, next thing you know, we're on 4 or 5 medications. And that we need to take a step back and say, do we need all of this? Do we need to get another EEG? Do we need to kind of do all the diagnosis and then maybe peel back some of the medications? Because I think when the adult neurologist when we're able to transition to the adult neurologist, I think they're going to be more comfortable knowing that we've tried these medications, these worked, these didn't work, this is what we're on now, and it's a reasonable list. Some people may need 4 medications, but I think it's something we need to kind of, around this time, kind of think, step back and think a bit about it. The other thing is, did we consider surgery? Did we consider diet therapy? The other treatment options that aren't always considered or aren't always thought about earlier. Finding an adult neurologist, epileptologist, unfortunately, this may be the most difficult slide, this most difficult step, but we're working on it. We're trying to form kind of a Southern California, consortium of some sort or a group of some sort so we can make direct contact with people, and it's even harder than just finding the right person. You have to find the right person who's in the right insurance. You need to find someone who's local. People come from all over, across the country to see us sometimes. If we could find someone who's nearby you to transition to, that would be much better. I mean, LA is brutal to drive around. I mean, we have people from even Bakersfield. If we can find an adult neurologist out there who's comfortable and you're comfortable with, then that would be ideal. Because anything we can do to kind of make the transition and make your lives easier would be best. We're not always able to do that, but when we can, we should. And then I talk about this more about therapists and psychologists than this, but I think it applies to here. Whenever I'm trying to convince one of my teens to go to a therapist, which they probably all should be going to, it's really important to say that just because you walk into someone's office and they're a licensed therapist and they do CBT, doesn't mean that they're a good fit for you. So you may go, I usually tell them to give them a couple times, but if you don't really feel comfortable, you don't feel good talking to them, it's a waste of your time to go. So you need to find someone else. You may need to try 2 or 3 different people before you find a therapist you feel comfortable with. And that goes for everyone. And it may be the same case for a neurologist or epileptologist. I mean, we've had patients go to an adult epileptologist or adult neurologist and come back and be like, yeah, no, I can't work with them. Okay, so let's find you somebody else. But just because it's the first one doesn't mean you have to work with them, you're stuck with them. We can work and find you someone. Might be a little bit further, but if you're more comfortable with them and they're going to be a better fit, then that's what we need to find. And then the pediatric discharge packet, that's something that we're working on. And the ideal situation is to have all of the information, all the records, and a pretty reasonable summary to give to the physician. I think one thing I know people are terrified of is a new patient comes in their office and they get a stack of medical records about this thick that's going to take 2 hours to get through. So we're working on a better way of summarizing the majority of that. What I really advise everyone to do is particularly reports for EEGs, imaging, genetic testing, any of those kinds of things, make sure you have a copy yourself. Make sure you keep a copy. When you go to a new doctor, you'll have it with you. The idea is that we're going to be sending it to them, but you having it yourself, I think, is most important. And then the other thing is also imaging. You always want to get the CD to bring the MRI to the next doctor too. Sometimes the EEG, but definitely the MRI. And then once all that transition is done, then an actual transfer. And this can occur a bunch of different ways. Ideally, I think it's nationwide, has a great system where their adult epilepsy or adult neurologist comes to the pediatric neurology clinic once a month and sees patients with their pediatric neurologist, and they see them together. It's a really good way, and they may do it 2 or 3 times before then they kind of take over the care of the patient. That's ideal. It's not always reasonable or realistic, honestly, because there's expectations of how many patients you see and how much you bill and all of that to basically keep the lights on. And 2 physicians at the same time, you're taking away from their other patients too. So it's probably the best situation, but it's also one of the most difficult things to do. So the other option is you come see us, and then your next appointment will be with the adult neurologist, but then your appointment after that will be back with us. So we bounce back and forth 2 or 3 times with us, us and the adult neurologist communicating about our plans and what's going on, but kind of bounce back and forth a few times before you feel more comfortable or comfortable enough to stay with them. How am I doing on time? 11:45. So I'm just going to go through this quickly. This is from the Dravet Syndrome Foundation. Danielle Boyce did a great study. I think she's going to have an abstract at the AES conference looking at the transition in Dravet patients, which tend to be one of the most difficult groups of patients to transition. They grouped it into 3 different categories, and basically they were asking families what they're most frustrated with, what's the most difficult things that they're having. The shortage of adult providers, the lack of knowledge of Dravet syndrome, I think that's big, and hopefully we can work on that with education. Uncomfortable intellectual disabilities, a lot of adult neurologists are. Adult providers, dismissive caregivers' knowledge, which we talked about that already. Barriers to accessing care, and issues not covered in clinic like guardianship. So we're trying to provide more of this here before you move on to the adult providers. Community programs. So we have a patient that has difficult to control epilepsy, but also has severe behavior problems. And she was too much for her family to take care of, and we needed to find her placement. And we found a great place that was comfortable with the seizures and been happy to take care of her, but they could not deal with the behavioral issues. We found another place that's what they're equipped for. They're equipped to deal with behavioral issues, but when they heard that she had epilepsy, we can't do that. And so finding one that's comfortable with both can be really difficult, and we need to encourage people to have and find programs like this. And when you do find it, tell everybody. So we were eventually able to get her seizures under a little bit better control, and finally one of the groups agreed. But again, fewer are comfortable taking care of both. And then in rural areas, very difficult to find. Many of these places tend to be in kind of more of the LA County type area, as opposed to Ventura County and Bakersfield sometimes. And then just home and social support. There is a lack of support, community support programs, kind of day programs. When you magically turn 18 or go into your 20s, you've been in school this whole time, and now what? And so there are some great programs out there, but there aren't enough. And again, they're hard to find. And we're working on working with families, and when we hear about something good, kind of keep an eye on that location to pass on. And along with this also is education. I mean, schools can be very, very difficult. Some school districts are better than others, but pretty much every school district is a fight of some sort. But that's what you kind of can lean on us for. That's like our social worker. That's what we're here to help for, whether it's letters needed or just advice, or I work with the IEP. So I think it's important, and one of the things that most parents say is they're just well, what happens when my child grows up and I pass away, what's going to happen to them? And I think the only thing we can do is educate yourselves right now, and I think that's what you're doing now, which is fantastic. And I think the more education you get, the more people you talk to, you can develop a really good, solid plan that everyone's comfortable with. I just want to acknowledge a few people, the Epilepsy Awareness Day group, Brad and Cindy, Candy, inviting me to come speak. The Epilepsy Foundation, who we do a lot of work with, who's a great resource for a lot of people. They do some really good work. The Care and Cure, this is another group that actually has helped fund our epilepsy fellowship, and those are all our fellows who were funded through them, to bring more pediatric epilepsy physicians into community. The guy down here, actually Don Phillips, he's at UC Irvine, or Chalk, and he's actually an adult neurologist who did our epilepsy fellowship. So he's kind of in a really good situation, and I'm going to be working with him soon to hopefully work on a transition program down in Chalk as well. And then finally, my group here at UCLA, and those are all our faculty and staff. So any questions I can answer? Thanks.
My child has autism and epilepsy. He's already 16 and that. Is it too late to go see you like your team?
No. So our center does a couple different things. One, we take care of our own patients, follow patients long term. The other thing we can do is a consult. And so if you stay with your regular epileptologist or neurologist for kind of epilepsy treatment, but come in and then we can have an evaluation with our OT, our social worker, dietitian, and all of that, and then make recommendations and give it back to your neurologist as well. So we've got two options.
And second question, I was unclear as to when they have to completely transition to adult care at 20.
So nobody's clear either.
Okay.
There really isn't. It depends on where you are. Some places have a hard stop. Something like a children's hospital has more of a hard stop because they can't admit patients into their hospital anymore above a certain age. I'm not sure if it's 18 or 21, depends on the place. We're kind of in a better situation because we're a hospital within a hospital, so we can still admit patients in their early 20s to the adult unit, but we follow them. So the goal is between the ages of 18 and 21 to make that transition, so by the time you're 21 to move to the adult care. But it doesn't happen that way all the time, so we follow kids into their early 20s. They may. I think everyone's a little bit different. I think if you do reevaluate and you're able to get clear data and clear information, whether it's genetic testing, MRIs, then they may be perfectly happy and comfortable taking that information. I guess it's possible that they want to do it on their own, but I think it varies. Our feeling is just, I think, because of the discomfort with a lot of our patients, I think the more kind of in better shape and more packaged our patients are, I think it would be more comfortable for them to take them. That's kind of why we've kind of approached it that way. Yep. Yeah, so I see a lot of Dr. Senkar's patients, so we work with the office and they can schedule, and then we usually have it scheduled to see everybody else in the clinic. I usually stop in and say hi, and then we make recommendations and send them back to Sankar. Correct. Yeah, so we have a specific diet therapy team that takes care of things like ketogenic diet, modified Atkins diet, low glycemic index diet. So that's a separate team. In our center, we have a dietitian who's basically working with kind of healthy eating and epilepsy. And there's not a fantastic data, but we're slowly accumulating data and we're slowly working on it. And so we kind of do what the typical diet therapy would do. They kind of get a diet record from you and then kind of make recommendations on, whether it be more whole foods type diets, less processed foods, less sugars, things like that. And then if the kind of a more advanced diet, then we bring you into the specifically diet therapy team. So our adult neurology program is outstanding. It's one of the top epilepsy surgery programs in the country. They don't have as many faculty as we do, and so they do have a limited amount of patients they can see. So for someone who's a surgical patient, there's no question that's exactly where I send them. Other patients, we do transition some to UCLA. I have found, though, that location and insurance tends to be two things that can make it even difficult to stay within the system. And then we're working with all the other hospitals and all the other physicians around the community to find the right fit. So it's a kind of a mix. And then honestly, there even different centers specialize in different things. Like we have the Adolescent Center, even like adult epilepsy groups specialize in certain things. A lot of my young women I send to don't tell anyone at UCLA I said this, but I send them to USC because Dr. Kalaji and Dr. Hecht are outstanding. They're phenomenal for treating women with epilepsy. And so a lot of those kinds of patients, especially if they live in that area, then I'll send them there because I think that's the best place for them. I think that's the key, is finding the best place, best fit. Other questions? Great. Well, I'll probably be at the booth for a while, so any other questions, feel free to stop by. Thank you.